Hello, welcome to today's session, Life After Transplant. I'm Jamie Lederer. I'm the ILD nurse practitioner at the University of Pennsylvania. Today, we're joined by three wonderful speakers, Dr. Reda Girgis, Carly D'Agostino, and Erin Mahoney. Dr. Girgis is the medical director of the lung transplantation program at Spectrum Health in Grand Rapids, Michigan, and professor of medicine at Michigan State University College of Human Medicine. Dr. Girgis has been practicing lung transplantation since 1994. Carly D'Agostino graduated from Butler University in Indianapolis with her doctorate in pharmacy in 2012. After that, she went to complete 2 years of pharmacy residency at Northwestern Memorial Hospital and then specialized in transplant pharmacy at the Ohio State University College of Pharmacy. Since then, she's been working as the team lead for the transplant pharmacy group at Northwestern Memorial Hospital, where she oversees both inpatient and outpatient care for both abdominal and lung transplant recipients. Erin Mahoney graduated from Loyola University with her Master's of Science in Nursing in 2011. She started her nursing career in 2005, working in the surgical trauma ICU. She's been involved in the care of the advanced lung disease and lung transplant patients since 2007. She was the recipient of the 2016 Fashion Knight Nurse of the Year Award by Loyola University Medical Center. She's currently working as a nurse practitioner with the lung transplant and advanced lung disease programs. She's married to her high school sweetheart and has 3 kids, 2 dogs, and a lizard named Abigail Felicia. After the presentations, we'll come back together as a group for a question and answer session. Please remember to submit your questions throughout the session in the box on the screen. And with that, I'm going to turn things over to our speakers.
Hello, everyone. Thank you for joining us for this session on lung transplantation. My name is Reda Girgis. I'm the medical director of the lung transplant program at Spectrum Health in Grand Rapids. And I'm also a professor of medicine with the Michigan State University College of Human Medicine in Grand Rapids. What I'd like to cover in the next 15 minutes are potential complications after lung transplantation. Now, this is a session that's directed towards patients and their caregivers. And what many people don't know is that the volume of lung transplants has really grown quite rapidly in the United States and really all over the world in recent years. When we look at this graph here, the number of transplants done annually in the United States, divided into groups, diagnosis groups of lung transplant candidates. And direct your attention here to this magenta line of group D, which is restrictive lung diseases. And that category mainly includes patients with idiopathic pulmonary fibrosis and other types of fibrotic lung disease. And you can see that since 2008 and really starting before then, there's been pretty rapid increase in the number of patients getting transplanted in this country, while the number of transplants in the other common diagnostic groups for which transplant is done, such the second most common one being group A, which is obstructive lung disease. That's mainly COPD and emphysema. Those are the 2 main categories of transplants. But you see that the restrictive lung disease group is approaching 2,000 per year now. This is data from 2019. And overall, there's approaching over 3,000 total lung transplants per year in the United States. So lung transplant is growing. I think that's the first message we want to take home. And secondly, the waiting time, once a decision has been made by the transplant center and the candidate that they want to be placed on the wait list, the time from then to actually receiving an organ transplant is relatively short. Again, direct your attention to the group D group, and currently the median wait time is in the order of 2 to 3 months for a patient with group D or fibrotic lung disease. So the wait list time is short, and the numbers of transplants being done is growing. So it's really a time of rapid growth, and it really shows us that lung transplant is really a viable option for patients with advanced lung disease, and particularly patients with fibrotic lung disease, such as idiopathic pulmonary fibrosis. Now, transplant is certainly can be a life-saving and life-changing intervention, but it's not all fun and games. And there are some serious problems, and both the healthcare team and the patient and their caregivers definitely need to be aware of the potential problems associated with lung transplant. Now, the survival after lung transplant is good, and it's not great, but it is getting better over time. This is, again, data from the same data set. This is from United States data, the SRTR, the Scientific Registry for Transplant Recipients, and they collect data from all transplant centers in the country. And if we look at 1-year survival here in green, that over time since 2008, again, we're seeing a reduction in the mortality, or the percent of patients who die at the end of 1 year. So we're approaching 10%. So that means that 90% of patients can expect to survive 1 year. And of course, that depends on the underlying illness of the patient and how sick they are coming into the transplant. But certainly the expectation for most programs now is a 90% 1-year survival. And if we go to 5-year survival, the expectation is 60% 5-year survival. And that compares to 50% just 10 years ago or so. And now we're starting to talk about 10-year survival. And that's really exciting for for someone who has been involved in this area for many years. We are talking about 10-year survival now that is approaching 50%, if it hasn't already done so. And so lung transplant outcomes now are approaching and are getting better. And they're approaching the outcome for other solid organ transplants like heart and kidney. And not only is survival getting better, but patients who do survive, the overwhelming majority of them have really good functional status. So they're up and around doing things they want to do and enjoying their life. So when I talk to potential candidates for lung transplant, I try to, and potential complications, try to divide them, think about them in 3 different categories. So the first are perioperative complications, which are things that happen during the surgery or around the time of the surgery. So the early course in the intensive care unit. And this is a critical time period, and we'll discuss that. Next are things that occur early, within the first few months to the first year, and then late complications are after that. So these perioperative complications, this is a difficult operation. It's a big surgery, whether it's a single lung transplant or bilateral, it's a big operation. And various things can happen and can go wrong. The biggest, most common problem is something we call primary graft dysfunction, where the lung gets edematous, meaning it gets full of water, and obviously doesn't function well when it's full of water. And that can happen for a variety of reasons, but it is probably the most common and perhaps most important early postoperative complication, and it can be serious. Again, it's a big surgery, so there can be bleeding, there can be technical problems if it was a difficult surgery. It can place the surgery places a big strain on the circulation, so we have instability with heart function, we have low blood pressure. These things can lead to other consequences, like acute kidney injury, where the kidney can fail temporarily. There can be consequences to the liver, to the gut, and even the brain, and can occasionally see strokes. So that's the early sort of perioperative complications. Then those are quick. Soon thereafter, we start dealing with these early complications that are seen in the first few months. So infections, of course, you need medications to suppress the immune system. So a transplant recipient is at risk for a variety of infections that an ordinary individual would not be susceptible to. These include various bacteria. And then we also have things that ordinary people would not typically have problems with, certain viral infections. And one particular virus is called CMV, or cytomegalovirus. And that's something that we have to deal with fairly regularly. We also have potential problems with fungal or mold infections. And then despite using the immunosuppressive medications, we can still deal with rejection. And in the early time points, in the early months, it's mainly a problem we call acute rejection. An acute rejection, where the body's immune system is attacking that organ, can take the form of what we call acute cellular rejection and or antibody mediated. And And that's just two different ways that the immune system is damaging the graft. The bronchial airway, where the two main airways are sutured together or around that area, sometimes that area can have trouble with impaired blood supply, and that can become narrowed or scarred down, and that can be a problem. There can be damage to the phrenic nerve that supplies the diaphragm. And then, as you'll hear later in this session, a variety of medications have to be taken. We can have a variety of side effects from those. Biggest problem long term, as I showed you, the 1 year survival is good. It's 90% on average, and actually a generally good candidate, healthy candidate, can really expect a 95-year, 1 year survival. So, but the late issues remain a problem, and the late complications, the biggest one is something referred to as chronic lung allograft dysfunction, or CLAD. Most commonly, it takes the form of an obstructive problem with lung function, meaning the bronchial tubes, the airways are narrowed and leading to obstruction of airflow. Less commonly, it takes on a restrictive lung problem where there's scar tissue that develops in the lung and the lung doesn't get enough air. So it's called a restrictive process. That's the most common and difficult problem long-term. Another potential long-term consequence that's fairly common is chronic damage to the kidneys related to medications and other issues. And then malignancy is more common after any solid organ transplant. And that's because the immune system is required to monitor the body for cancers as well as infections. So a variety of potential cancers listed here. Now, I want to spend a little bit of time talking about the chronic lung allograft dysfunction, or CLAD. Again, the most common manifestation is what we call obliterative bronchiolitis. So the bronchioles are these small airways. So here, direct your attention to this larger figure here that shows the main windpipe or trachea, divides into bronchi, and then there's a very extensive tree-like network where it branches out. And when you get down to the smallest airway, they're called bronchioles. And normally they have a relatively thin wall and their lumen is nice and patent. And what happens with obliterative bronchiolitis, and here is a microscopic then section of one of these bronchioles in cross section, and you see that the wall is becoming thickened here by this scar tissue. And then sometimes the lumen here, you can't even make out the lumen, but this is the wall of that bronchiole, and it's obliterated or occluded by these cells here, all these blue dots. And then in this example down here, it's actually, this is a vessel, an artery that's, and then adjacent to that artery, normally we find a bronchiole airway, and you see that's, it's just not there anymore because it's obliterated by this scar tissue, hence the term obliterative bronchiolitis, or OB. So that's the pathology of this process. And that's helpful to understand, is that we get narrowing and basically loss of these smallest of airways. And we classify or diagnose CLAD based on lung function. We don't diagnose it based on pathology or lung biopsy. It's a clinical diagnosis. So we monitor lung function, spirometry, very closely. Now, as an IPF patient, you're maybe aware that the doctor follows your FVC, the vital capacity here. We're following that as well, but we're paying more attention to the FEV1, which is more reflective of an obstructive process. And the FEV1 is the forced expiratory volume in the first second of that exhalation maneuver with spirometry. And as it declines, the CLAD stage advances. So that's how we classify it. Now, I just want to mention, it's not really understood why people get this chronic rejection process, but there are certain risk factors that are identified. And among those is acute rejection, so things that happen early on, where there's inflammation in the lung, CMV infections in the lung, bacterial and mold infections, this primary graft dysfunction. When that occurs, that seems to make patients at risk for the subsequent development of chronic rejection down the line, having gastroesophageal reflux, and also having what we call donor-specific antibodies that are targeting the organ, and leading to this process we refer to as antibody-mediated rejection. Now, I want to wrap up by just pointing out that there's a lot of it is an exciting time in lung transplantation. There's a lot of research going on, which is really something fairly new in lung transplantation. I think the reason for that is I showed you the numbers for volume, and in the past, lung transplant volumes were relatively low, and so it's hard to study and get information or have evidence, or to do large multi-center studies to look at different outcomes. And there just wasn't a lot of collaboration. Basically, every center was doing its own thing. But I think now with the volumes being growing, people recognize the need to study how we manage patients in lung transplantation and come up with new things. And there's a lot of that going on. And this is just one example of that. So talked about all these complications that can occur, whether it be rejection or infection. And one of the things that we do to monitor for that is a bronchoscopy. We put a lighted scope in through the lungs, and we take samples, including a biopsy, and have that looked at underneath the microscope to see if there's any signs of acute rejection or other pathology. Now we have a test that is going to be, we're going to see more and more of. It's a blood test. We take a sample of blood and we look for cell-free DNA that has been determined to be derived from the donor. So circulating, so when any tissue in the body gets damaged, the cells release DNA into the bloodstream. And techniques now can identify that DNA as being donor-derived. Well, if it's donor-derived, see DNA circulating in the bloodstream, that must mean there is injury to the graft. So it seems to be a pretty good indicator of some kind of injury, damage to that graft. And when in this study that looked at the ability of this test to identify acute rejection, you just measure it in these different situations. You see people who don't have any rejection, they have relatively low of percent circulating donor-derived cell-free DNA in their blood compared to people with acute cellular rejection or acute or antibody-mediated rejection. And then the acute rejection here, both of these together. So if we look at what's something called the receiver operator characteristic curve, it's something common when we look at a diagnostic test to see how sensitive and specific it is. I won't go through the details, but the area under this curve is relatively high at 0.89. The better the diagnostic accuracy of a test, the closer it is to 1. And therefore, and along with this, the negative predictive value then for this test to rule out acute rejection is 95%. That means if you get a patient that has no clinical evidence of rejection, right now the standard of care is to do a bronchoscopy on that patient and just make sure. Well, now we have a blood test that can tell us with 95% likelihood that there's no acute rejection. That's very useful clinically because it can reduce the need to do surveillance bronchoscopies. And there's 2 commercial assays available on the market now. We're going to be starting to use them in a lot of centers. We'll see I think we're going to hear more about this as a clinical trial comparing management strategy using this test. So that's very exciting. And there's a lot of things that we're going to see new and exciting in lung transplantation. So it's an exciting time. And I'll stop there and thank you for your attention.
Hi, everyone. Thank you so much for listening in today to our next topic in life after lung transplant. My name is Carly D'Agostino, and I'm one of the clinical transplant pharmacists at Northwestern Memorial Hospital in Chicago, Illinois. I work specifically with lung transplant patients as well as kidney, pancreas, and liver transplant patients in the inpatient and outpatient settings. And today we will be going over the common medications after lung transplant, as well as discussing changes to the medication protocol after lung transplant as well. So I want to remind you all that your new organ, your new lungs, is a precious gift. Honoring that gift means staying committed to lifelong care and taking all the steps that are needed to protect you and your transplant. One of the most important things that we'll discuss is that you will need to take medications for life after transplant. So why do you ask that you need to take medications for the rest of your life? It's because a major concern after lung transplant is the risk of rejection. Rejection can happen at any time when your body stops accepting your new organ or your new lungs. When this occurs, your immune system attacks your new organ or your new lungs as if it does not belong in your body. Your anti-rejection medications help prevent this rejection from occurring. However, rejection can occur at any time, even years after your transplant. So this is why it's very important that you must always take your medications. What can you do to try to prevent rejection of your new lungs? It's important that you take your medications every day at the same time. Do not miss any lab or doctor's appointments. Keep track of your medication dosages as they change, and get your refills on time or early so you don't run out of medications. So obviously, the first group of medications that we'll talk about are your anti-rejection medications, also known as immunosuppressants. You will take a combination of at least 3 anti-rejection medications after lung transplant. They work together to help prevent your immune system from hurting your new lungs. You will also be asked to get regular blood tests because these tests will monitor how well the medications are working. They may help in detecting signs of rejection, and they will reduce the chance of side effects or infections after transplant. These blood tests help the transplant team adjust your medications so they can better meet your specific needs. The first medication that we'll talk about, the most common anti-rejection medication, is called tacrolimus, or the brand name is Prograf, that maybe your doctors and nurses will refer it to. The capsules are shown here, and you will be instructed to take a certain number of capsules twice a day. It's important to take these medications at a consistent time, about 12 hours apart, and obviously to not miss any doses. The transplant team will be monitoring how well this medication is working in your body by getting blood levels checked of this medication and to determine if your medication dose needs to be changed. So whenever you get your blood drawn on blood draw lab days, we ask that you do not take your tacrolimus in the morning before you get your blood drawn. We will ask that you take it after the blood is drawn, and this will happen for the rest of your life while you're on this medication. The next medication is called mycophenolate mofetil, or the other name for it is Cellcept, and it is available as capsules or tablets shown right here. Again, you will take the instructed amount of capsules twice a day and to take them at consistent times and to not miss any doses. We ask that you take them the same as tacrolimus, about 12 hours apart, and you may take at the same time as your other medications. With this medication, you can take it with or without food. One of the biggest side effects that mycophenolate can cause is nausea, vomiting, and diarrhea. We will not go over side effects in this topic, but you will review them with another presenter. So we do recommend that it might be best to have this medication with a small meal or snack to prevent these side effects. It's important to be consistent with the amount of food since food can affect absorption. The third anti-rejection medication that you will likely be on is prednisone, or an oral steroid. This you will be instructed on taking a certain number of tablets, usually once a day in the morning. You can take this prednisone at the same time as your other medications, and once again, it's likely best to take it with food, especially with a small meal or snack, because one of the biggest side effects is stomach upset, so having it with some kind of food in your stomach will be best to prevent that. The next section of medications are preventative medications. So anti-rejection medications will weaken your immune system, and this can make you more likely to get certain types of infections. You will have to take certain medications to help protect you from getting these infections. Those can include antibacterial, antiviral, and antifungal medications. You will also need to take certain precautions to avoid getting infections. Wearing a mask in a crowded area, which you're probably already doing, washing your hands regularly, and avoid being in contact with sick people. The first group of anti-infective preventative medications is antiviral medication. Valganciclovir or Valcite is one medication, and then the other can be valacyclovir or Valtrex. The transplant team would instruct you to take 1 or 2 tablets of one of these medications, usually once a day in the morning. You may be on this medication for 6 to 12 months, but it will be up to the transplant center to tell you how long you'll be on it. The next group of medications are your antibacterial medications. Most likely you will be on a medication called sulfamethoxazole, trimethoprim, or the brand name is Bactrim, unless you have an allergy to a sulfa medication. Usually you will take this medication 1 tablet 3 times a week on Mondays, Wednesdays, and Fridays. Once again, the transplant team will tell you how long you can expect to be on this medication as it varies per transplant site. And finally, you will be put on a medication to prevent fungal infections. They may be posaconazole or voriconazole, and you will be on it for a certain period of time after transplant. Posaconazole and voriconazole are similar to the first anti-rejection medication we talked about, tacrolimus, as you will wait to take your morning dose until after your blood is drawn on clinic or lab draw days. In this way, we're able to monitor how much of these drugs are in your blood and if we have to change the dose. After anti-rejection and anti-infective medications, your transplant team will talk about other medications that you will be on after transplant. One of them can be pain management after a big surgery like a lung transplant. And your transplant team will discuss the pain medication options that you have depending on your surgery and level of pain. It's usually recommended to avoid all non-steroidal anti-inflammatory drugs such as ibuprofen and naproxen, and that's because they may cause damage to your kidney over time in combination with your other anti-rejection medications. So it's important to always check the ingredients of over-the-counter medications to ensure that you're avoiding these types of drugs. The next group of medications that you will most likely be on after transplant is an acid reducer, either famotidine or something like pantoprazole or another one in that class. The goal of these medications are to prevent heartburn, ulcers, and acid reflux. Acid reflux must be avoided after transplant to prevent damage to the lungs. So these medications are very important to be on after transplant. And it's important to take them even if you do not feel like you're having heartburn symptoms. You still need to be on these medications. Finally, your transplant team may recommend to put you on some vitamin supplements after transplant. These can include calcium and vitamin D, which is important for bone health, especially while you're on medications like prednisone. So you may be instructed to take one tablet once or twice a day. Magnesium oxide may be added to your medication regimen as well, as this will increase your magnesium levels and prevent heart and muscle issues. Once again, it's up to the transplant team for how much you're supposed to be on and for how long you will be on this medication. Before transplant, you're probably on medications right now, and it's up to the transplant team to determine what medications you will resume after transplant and what medications you will stop. Some things that you will most likely resume or have altered may be current blood sugar medications, current blood pressure medications, cholesterol lowering medications, or other maintenance medications. Usually a pharmacist or a member of your transplant team will review all your medications with you and your caregivers prior to you discharging from the hospital. It's very important to let your transplant team know before you start any new medications, either from your primary care provider or another physician. Many medications, including and most especially herbal supplements, can interact with your anti-rejection and anti-infective medications, and they may cause problems. So medication interactions is very important and very important for your transplant team to be aware of after transplant. In terms of food interactions, it's important to avoid grapefruit or grapefruit juice, as well as pomegranate or pomegranate juice after transplant, as these can interact with your anti-rejection medications. It is okay to take medications with or without food, as I mentioned earlier, but it's important to be consistent about the amount of food that you're having with each of your medications. We recommend that you avoid high-fat foods with your medications, as sometimes these can lessen and decrease medication absorption. The next section that we wanted to go over were changes to the medication protocol after transplant. So medication changes can happen at any time period after transplant. You can expect to have the most medication changes usually earlier on after transplant. And medication protocols are made for patients initially after transplant, but then they usually need to be individualized for every patient. One size or one medication regimen or one medication protocol usually does not fit every single patient, and so that's why changes need to be made. Some examples of medication changes could be dose changes due to your drug levels. So remember, we talked about tacrolimus and how you're going to be getting your blood checked every time, your blood checked frequently after transplant. If the blood results or the lab result comes back either too high or too low from the goal of your transplant team, you may be instructed to increase or decrease the number of capsules of tacrolimus that you take during the day. And so that may be an example of a dose change. In addition, side effects can occur with all medications, as you'll learn in another presentation, specifically something like mycophenolate, and we talked about a side effect of nausea, vomiting, diarrhea. And so sometimes the transplant team will adjust the dose based on those side effects in order for you to tolerate the medication easier. Also, because of side effects from the anti-rejection medications, you may be instructed to stop or start new medications to help with those side effects. For instance, anti-rejection medications can increase your blood pressure and they may increase your cholesterol. So you may be instructed to start either a blood pressure medication or a cholesterol lowering medication to help with those side effects. If you were to have a rejection episode after transplant, you will likely be started on new medications. These can include IV or oral steroids, such as a high-dose prednisone taper, and that will be instructed by your transplant team. And finally, as we mentioned, you may be instructed to stop certain anti-infective medications after a certain period has finished after transplant. You will never stop medications on your own. You will wait to hear from the transplant team if you're supposed to stop or start new medications. So when can you expect these changes to occur? As we mentioned, they can occur at any time after transplant, but most likely they may occur after a clinic appointment with your transplant team, maybe after your blood is drawn and the lab results come back. So like I mentioned with tacrolimus, you may have your nurse coordinator or physician call you over the phone to adjust the dose, or it may occur after a hospital stay. It's very important to stay organized, ask questions if you're unsure about the medication regimen, and use your caregiver's support and care to help with the medication setup. So in conclusion, I wanted to just give you a few reminders of how to remember to take your medications. You can use a treatment diary or a day planner to help with your reminders. You can organize your medications in a pill box with a timer or labels with days and times. I usually instruct patients to have the patient and a caregiver helping you with the pill box, as these medications can be very small and look very similar, and so it's best to have two eyes on the medications at all times. You can write down the details about each medication, what they look like, what the dose is, when to take it, any side effects to report. And it's important to make medications a part of your daily routine. And you will get into a routine after transplant. It just may take some time for you to get into back to your normal routine. So you can take them after you shower or after you eat breakfast. A good recommendation is to use an alarm that will remind you to take your medications at the same time each day. And there's different applications available on your smartphone, one being the Transplant Hero app that can help you stay on schedule and set alarms to encourage you to take your medications. So in conclusion, remember that you are the most important part of your transplant team, and the success of your transplant depends on you taking an active role in managing your health. Thank you so much for listening in, and I look forward to answering your questions in the Q&A session. Thanks. Goodbye.
Hello, my name is Erin Mahoney. I am here to talk to you about what to expect from side effects following your lung transplant. I am a nurse practitioner at Loyola University Medical Center in Chicago, and I work with advanced lung disease and lung transplant patients throughout their journey to lung transplant. I hope we can have a good discussion today. So my objectives of this talk is to first discuss the definition of what a side effect is, and then to kind of go through different types of side effects I hear from my patients, and then talk about possible treatment options. If you can see this picture on the right, you'll see a baby Erin Mahoney with her arms crossed, procuring some lungs. That's how I started my journey with lung transplant, was going out and getting donor lungs for my patients. So the definition of a side effect is a secondary, typically undesirable side effect of a drug or medical treatment. So if you think about it, most people think about side effects as medication related. But if you think about the medical treatment, what is the ultimate medical treatment we're talking about? We're talking about a lung transplant. So I'm going to be talking both about medication side effects and about medical side effects related to your lung transplant. So first off, medication soup. One of my other speakers in this session talked about some of the complexities regarding medication. And so this is something that I hear a lot from my patients. I am on 3 medications to prevent rejection. What are the other 15 medications for? This is an example of a medication schedule I sent with my patients last week when I discharged them from their lung transplant. And if you can count all the tiny boxes, there's 30 different boxes there reflecting 30 different medications. It's a lot of meds. So medication side effects are extremely common, and some side effects are permissible. What that means is I'm expecting you to have some of the side effects. When I throw 30 different medications at you all at once following your lung transplant, I'm going to expect some things to go wrong. And so we oftentimes treat medication side effects with more medication, which can be quite cumbersome. I'll give you an example of that. Everybody following lung transplant is on prednisone. So we all know the lovely side effects of prednisone can cause you to have high blood sugars. And for that, I may give you an oral medication to treat your blood sugars. I may give you insulin. So there's 2 drugs right there. I also may have to give you some diuretic to treat the swelling in your legs from the prednisone. So there's another medication right there. And then you may have hypertension from the prednisone, and so I'm going to give you a medication right there. And so that's now, 6 medications to treat the one side effect from, or the multiple side effects from prednisone. So it's really, really important to learn your medications, know what they are and why you are on it. I think that a lot of issues regarding medications can just be from a lack of knowledge of why you're on it. And sometimes patients stop medications thinking they're not important anymore when actually they are working. You just don't know they're working until you stop the medication. Stay super organized. Please use a pill box. It's really hard to keep track of 30 medications all at once. Use alarms if you have to remind you to take your meds, and travel with a 1-day supply of medication. I can't tell you how many phone calls I get from people that are at visiting relatives and something happens and they get stuck there, and I'm having to call 1-day supplies to a local pharmacy in Vermont because they ran out of meds. So very, very important to stay organized, know your medications and why you're on it, and then talk to your team about if you're having any side effects or any new changes with a medication start. So this is another thing I hear a lot. My lungs are great, but everything else is bad. Or my lungs are great, but I keep getting admitted. And if you can see on the bottom, there's a picture of a patient and there's a picture of a doctor, and they're both doing the shrug shoulders. And that's what it feels like sometimes when we're talking about medical side effects. And so there's a lot of medical side effects related to lung transplant. Just think about those 30 medications that I'm giving you. A lot of them can be short-term side effects, things like steroid-induced diabetes, GI complications, people have looser stools following transplant, high blood pressures, having problems with your kidneys, and then of course infection, and then the infamous rejection. And if you can see, the treatment options on the side looks a lot alike, right? So when you have steroid-induced diabetes, I'm going to ask you what you're eating. If you have GI complications, I'm going to talk to you about your fiber intake. If you have high blood pressure, I'm going to talk to you about if you've been gaining weight and if you need to lose some weight. And if you have kidney dysfunction, I'm going to talk to you about your water intake. So there's a lot of things that I can do to try to modify your diet to help treat these medical side effects that you might have from your lung transplant. But if those things don't work, or if they don't work good enough, then I'm going to start changing your medications, adding new medications, seeing what I can do to help treat these side effects. Of course, infection and rejection, there's really not a lot I can do to treat that besides give you medication. So unfortunately, that's what we're going to do, is we're going to give you some medication either antibacterial, or we're going to give you some more prednisone to treat the infection and rejection. And then of course, sometimes side effects need to be treated in the hospital. And that's where it comes in, where your lungs may be great, but I have to admit you because you have kidney failure, and I need to correct your kidney function in the hospital. And of course, some of these short-term side effects can definitely lead to long-term side effects, but the treatment options remain the same. So mental health, this is a really big topic that I would love to spend more time on. But I hear this a lot from my patients. Why did I do this? Why did I have a lung transplant? This is a lot of work. Or I feel like such a burden to my family. I keep having to ask them to do a lot of things for me, and I can't do it myself. So what's the treatment plan for that? For anxiety, it's a lot to adjust to your life after transplant. You come into the hospital needing, 14 liters just to get to the bathroom, and you walk out on room air. That's a big thing. And so a lot of times people have a lot of anxiety getting through kind of what their life is going to be like after transplant. And of course, they're worried they're going to mess things up. And so we have you talk to psychology to discuss coping skills. We have you meet with a support group. Support group and mentorship is huge. It's really important to talk to other people who have been through a lung transplant so that you know you're not alone. And then finally, if you need medication, we'll have you talk to psychiatry and get you on some medication. Depression is another thing that we deal with a lot with our patients. So the expectation of transplant doesn't necessarily meet the reality that you are faced with. Everyone thinks their life is just going to be sunshine and roses following lung transplant. And unfortunately, sometimes there's bumps in the road and you got to be able to weather those. And so again, psychology and psychiatry are really, really important tools in your toolbox to have to help treat depression. And then finally, feeling like a burden to your family. Caregivers are identified before you even have a lung transplant. Most lung transplant centers vet 2 different caregivers. And so these people are very aware of what they're going to be doing to help you following your lung transplant. And there's caregiver support groups to discuss, to help them rely and cope on each other so that they are good caregivers for you. And so it's really, really important not to feel like a burden to your family if you need help. And then finally, time flies and yet stands still. This is a big topic for me. So what I mean by this is a patient that told me this. I have to pick up and start this medication tonight. I had concert tickets, and now you're telling me I have to go to this specialty pharmacy 2 hours away and pick up this medication, and it's a Friday night? Or why do I have to wait so long for test results? I had that test 2 weeks ago, and you're telling me it's not back yet. And so that's the hurry up, and that's the wait with transplant. And so with these, I just think it's so important to work with your transplant team. If I call you on a Friday night and I say, your kidney function is bad, your lung function dropped a little bit, your hemoglobin A1C is up, that's a lot of things I'm throwing at you all at once. And so if you are feeling overwhelmed with all of those things I'm throwing at you, ask your team for priorities. What is the most important thing you want for me to tackle today? And I can usually give that to my patients. I want you to focus on your breathing right now. Next week, we're going to talk about your sugars, okay? The other thing is know the players in the game. So if you are having a side effect and the side effect is I have high blood pressure because I've gained a little weight following Thanksgiving, know who the dietitian is and then ask to have an appointment with them or have a video visit with them to talk about some dietary modification. Again, if you remember those list of possible treatment plans, a lot of things can be treated and helped with diet. So we're not relying so much on medications all the time. But you have to know the players in the game to reach out to them and see if they can help treat your side effects. And finally, communication is key. It's so important to communicate with your transplant program. I really view transplant as a team sport, and you are the captain, you are the quarterback. We can't do it without you. And so if I don't know what's happening with you, I don't know that I need to treat or change something to make you feel better. And then finally, trust the process. Side effects can take time to fix. I wish I had a magical wand that I could just wave and poof, all the side effects would be gone. But it doesn't work that way. And so I may make a small adjustment to your medication, and I'll call you in a week and say, is that better or is that worse? And then make another small adjustment to your medication. And again, lab monitoring and frequent medication changes are very normal following lung transplant. You can be on the same dose of Prograf for 2 years straight. And if you see me in clinic and your Prograf is too low, I'm gonna adjust it. And then I'm gonna ask you to repeat a level in a couple of weeks. It's just the name of the game following lung transplant. And so trust in the process and work with your transplant team. And remember, transplant is a team sport and we have to do it together. And finally, we talked about a lot of really, really heavy things and kind of bad things that can be happening with transplant. But I want you guys all to remember to enjoy the ride. These are some of my wonderful patients that I have taken care of through the years. Remember to, when it's not in the middle of a pandemic, come back to the hospital and come meet the patient, the nurses that took care of you. They'd love to see you in the hospital, out living your life, like my friend Pastor Kyle. Go and speak and share your story. This is one of our lovely patients who spoke at a conference about her journey to transplant. Partner with your transplant team. This is my patient down in the corner talking to his transplant coordinator in clinic. And then finally, if you want to be my friend in the bottom right, Mr. Bob, and you want to climb up the Hancock with me in Chicago, which is 94 flights of stairs, do it. Talk to your transplant team, come up with a treatment plan. As you can see, he's in pulmonary rehab training to climb up that very large building with me, which we do every year with our patients in Chicago to raise money for the Respiratory Health Association of Chicago. And so enjoy the ride, live your life. We don't transplant patients for them to live in a bubble, and just recognize that we are here to support you in your dreams. I believe that there will be a session for live questions at the end of this. So please write down your questions. If you have any questions, I'd be more than happy to answer them for you. And thank you so much for your time.
Wow, those talks were excellent. Thank you to all of you for sharing with us today. I know I learned so much and can only imagine what our audience has learned today. There are a lot of questions that have come in, and so I'm going to start diving into them and hope that you guys can provide some great answers for everybody that's listening. So we'll start. Dr. Girgis, the question from the audience was, what's the average lifespan after transplant?
Yeah, thank you. So I did show that at the beginning of the presentation, for average population. So the good news is that survival continues to improve over time, particularly the long-term outcomes. So right now, the median survival is 6.5 years. That means that after 6.5 years, over half of the recipients can be expect to still be alive. So, and I think that gets a little bit better, as we go along and make refinements in what we're doing. So that's the average. Of course, it's going to vary based on, a lot of things, the age of the recipient, a little bit worse. There's another question I see about, older people, so we can cover that as well. I mean, older people can certainly do well. So there's not really a chronologic age that should be a focus. It's more, how fit the individual is and if there's other illnesses beside their lung condition. But obviously, the older you are, then the long-term outcomes are going to be a bit less, just because other things happen to older people. So 6.5 years is kind of the average, but that means that there's still the potential for much longer. There are many people walking around that are past 20 years now, so there certainly is potential for long-term survival.
Great, thank you so much. Carly, there was a question from the audience asking, do insurance companies pay for all of these medications that transplant patients have to take?
Great question, because there are so many medications. Before transplant, during your transplant workup, there's a very in-depth work with your social worker, in which we evaluate your insurance. Sometimes we can even run test claims with the pharmacy to ensure and get an idea of copays. But usually, depending on your insurance, we can get them to be affordable and make sure that they're affordable for you. We can enroll you in patient assistance programs if the cost is too high for you, just based on your insurance and their formulary options. But for the most part, we are able to get them covered through insurance in some regard, or we work with you and the social worker to get you set up with a patient assistance program.
Great, thank you. Erin, are there things that your patients can no longer do after transplant, such as swimming in lakes or sitting at the spa? And where can a patient find reliable information about things that they're restricted upon after receiving a transplant?
That's a great question, and there's a lot of meat to the bones in that question. So I would say a great place to start is to look at unos.org, and there is a Living with Transplant section that's dedicated strictly to patients that has a ton of resources on it. And I would say you need to talk to your transplant program. There are a lot of restrictions after transplant. I don't especially want people sitting in a hot tub at the local pool with a bunch of people when you're immunosuppressed. But I really like to focus on what we can do following transplant rather than what we can't do. And arming yourself with knowledge from your transplant program is the best way to start.
Great, thank you so much. Carly, one of our audience members asked, would a patient be on tacrolimus, mycophenolate, and prednisone all at the same time? And does anybody ever eventually come off of these medications, or are they lifelong?
Great question. So that's the normal, and I would say majority of the backbone of the anti-rejection regimen that lung transplant patients are on immediately post-transplant. However, because of every patient is an individual and tolerates medications differently, we may switch you to another anti-rejection medication or try something else. But for the majority of lung transplant patients, they will be on the combination of the three for life at this time. We have the best outcomes with that combination.
Perfect, thank you. Dr. Girgis, one of our audience members asked, is the donor-derived cell-free DNA a blood test that's drawn regularly with one of the 2 commercial assays available?
Yeah, thank you for that. So it is, these tests actually just recently became kind of widely available for general use. Previously, they were in research studies. So both of them, there's 2 commercial assays out there. They both show reasonable ability to exclude rejection in an asymptomatic patient. So it is a blood test. Yeah, so it's a simple blood test, and send it out to the specialized lab, and they run it, and they give us a number. It's below a certain threshold. That's reassuring. So really, they just came out. We're really starting to get experience with them, and we need a little bit more time to understand how we're going to use them in our clinical practice.
A follow-up question that was asked in regards to that was, if you do draw the assay, what action is taken upon the results? Will a patient get a bronchoscopy, or are there other actions that are taken?
Yeah. So the thinking for how we're going to use this perhaps is, if we're comfortable that it is a reliable test, and we want to get some more data on it still. But I think in the future, if it works as it's supposed to, we would check that test on a regular basis every month or every 2 months, however often we think it needs to be drawn, as long as the patient's doing well. And if it's below the certain threshold, then there would be no need to do a bronchoscopy. But if the test came back above the certain threshold, or there was any symptoms, so change in the lung function or symptoms or chest x-ray abnormality, then we would do the bronchoscopy at that time.
Perfect. Erin, one of our audience members asked, to qualify for transplant, does a patient before their transplant need to take all of these medications to make sure they tolerate them ahead of time?
Oh my goodness, I think that sounds like torture. So I hope we don't do that to people. Unfortunately, we don't. I do appreciate that question, because that would be a great way to see if you have side effects to things. Most patients, by the time they've come to us, they have been on prednisone at some point in time in their life. And so we will have a good understanding of how you react to prednisone. But unfortunately, it all happens after transplant. And that's why you get monitored so closely after transplant and seeing your team weekly oftentimes. So we can monitor you for these side effects and treat them appropriately.
Carly, are there any contraindications with these medications if wine or alcohol is taken around the time that you take the medications?
That's a great question. So really a lot of the issue with wine and alcohol is also an interaction with your anti-rejection medications. And so a lot of it has to do with the amount. And so we generally recommend trying to avoid wine and alcohol after transplant. And then we can talk about it on a case-by-case basis, depending on, how far out you are from transplant, the types of medications that you're on. But the timing is challenging because it's still in your system. And so usually we say, and it's up to same thing with your transplant center, but to avoid initially, and then it can be discussed once you're on more of a stable regimen of medications.
Great. Erin, if an ILD patient with IPF receives a single lung transplant, are they still considered an ILD IPF patient because of they still have their native lung?
They are. So that native lung is still in there. And if you give an IPF patient enough time, when you're looking at their chest x-ray, they'll have their beautiful transplanted lung on one side, and that native lung just continues to shrivel up and get smaller and smaller and smaller. It's very interesting to show patients this x-ray because by the end of 5 years or 6 years, they're oftentimes just being supported on their one lung.
Great. Carly, can you speak to, with the restrictions that transplant patients have, why foods like lettuce and cold cuts are restricted?
So you'll meet with a dietitian as well after transplant. And really it's due to kind of the bacteria and making sure that the vegetables that you eat are clean and washed appropriately. And same with the cold cuts, it kind of depends on where the meat is being taken from the deli versus in a package, mainly because we don't want to introduce the risk for bacteria to kind of harbor in those in those foods and be a risk for a patient who's already immunosuppressed.
Perfect. Looks like we have time for another question or two. Erin, I know you've worked with patients before and after transplant, so I think you could probably speak to this. Besides a healthy diet and exercise, are there other things a potential transplant patient can do to prepare for transplant?
I can't stress enough the mental health aspects of a journey into transplant. I think that we all tend to, focus on the physicality of it. And enrolling in pulmonary rehab and walking and everything is great. But I think that just mentally preparing for a transplant is almost as important as physically preparing. And that's why I really encourage patients to join a support group. Most lung transplant programs have a support group. Find a mentor, join the Facebook groups. There's a bunch of Facebook groups, and just arm yourself with as much knowledge as possible going in for you and your family, so that you're not throwing curveballs, when you're in the hospital and not expecting things.
Excellent. Well, I just want to thank you all for joining us today. This has been quite informative. Thank you to all of our speakers. And I hope you all enjoy the last couple of days that are left of the summit. There are lots of good talks that are still scheduled, so be sure to check those out. And I believe all of the social events are this evening too, so please hop into some of those. All right, take care and have a good rest of your day, everybody.